now? Okay. Thank you. At the outset, I'd like to thank SGI for giving me this opportunity to speak on this important topic of optimal reporting in EUS. We all do EUS, but the problem of doing an EUS is that we need to report it adequately for adequate patient care, proper patient care, and definitely for someone else who has been reading the report to adequately interpret it. As a result, in the next 10 minutes of my allotted time, I'll speak on how to optimally report in EUS. So whenever we talk about a quality of endoscopy reporting, this is essential for a better patient care. The better endoscopic reporting helps to interpret it better for a better and future patient care. This is basically conveying the message as to what happened to someone who was not there during the endoscopy. It's simply something like that. So and as we have all known that US over the ensuing years have become not only an important diagnostic, but also a very important therapeutic modality for various GI diseases. And frankly, there are very, very limited literature which is available currently as of now for a standardized US reporting. So I'd first like to answer the question as to why do we actually need a standardized US reporting or an optimal US reporting is required. The first and the foremost is quality indicator. Various aspects of the US reports, various aspects like how frequently was the examination done, how frequently was antibiotic prophylaxis given, etc. Various points on the US reports are used as quality indicators. So by looking at the adequacy of the US reporting, one can adequately say about how good or bad the procedure was done. So it is an important quality indicator, the US report. Definitely, it allows for ensures a better and appropriate and timely patient care. It is definitely very important for medical legal purposes for an adequate and optimum US reporting. And finally, optimization of research. A good and structured US report will enable it to be interpreted universally. It will act as a language for all and hence help and benefit in optimization of the research. So first, I'll speak on two important concepts. One is minimal standard terminology. This is something which has been formulated by the World Endoscopy Organization. They had various versions of it. The latest version is MST 3.0, which is available on the World Endoscopy Organization website. This basically provides a framework. This framework is to optimize the terminologies that are being used while describing the various findings, whether you do an upper GI endoscopy, you do an URCP, or EUS. So it basically gives an objective definitions or objective terms to be used during the reporting of these various procedures so that the operator need not be there when you are trying to interpret the report. So it gives certain basic key elements. And when we are using these kind of minimal standard terminologies, then the report becomes much more acceptable and usable during a longer period. So there are two things. One is using a descriptive report, like what the operator thinks he has found and kind of reporting it. And the other is using this kind of a minimal standard terminology so that it is universally understandable by anyone who knows the various terms. So the website clearly gives these kind of US findings, which has to be kind of the terms that needs to be used while you are trying to describe the findings in the US. Let's say the intramural lesion, wall thickening, polyp, mass. Then they clearly give as to what are the various things that needs to be mentioned when you're talking about an intramural lesion. Let's say the shape, the character, the margin, features, etc. Again, when you talk about any particular lesion, then how is the shape and the character should be defined. Let's say round, oval, triangular, linear, crescent shape, etc. So these are the various standard terms that have been defined. And these are the terms, if when used, can actually carry a more uniform meaning than the endocrinologists using their own kind of terms. And definitely when you talk about EUS, we talk about echo features. So these are the various normal, anechoic, whether the lesion was hypoechoic, isoechoic. These are the various standard terms that needs to be used while reporting your EUS report. This is first part, that is minimal standard terminology. And rather than going for a descriptive report, as many times the endocrinologists tend to give, the benefit of a structured reporting, a format, is essential because of two important reasons. One, it gives a more objective interpretation of the report that has been given, and definitely it enables the endocrinologist to do it with much speed. So when you have a structured reporting format, it enables the endocrinologist to just tick all the points or the marks that needs to be kind of looked into a particular lesion, and also ensures that we are not missing anything. So it ensures the completeness of the report as well. Having said that, so when we talk about an EUS reporting, ideally an EUS reporting should have three basic segments. One is the pre-procedure segments, or the details which are needed prior to performing any procedure, then the procedural details, and definitely the post-procedure details. So I'll first come to the pre-procedure segment. So the pre-procedure segment should contain some basic facts like the date and the time of the procedure, what is the type of the procedure done, what is the echo endoscope used, whether it's a radial, a linear scope, and the make of the scope, whether it's an Olympus scope or a Pentax scope that has been used. Then definitely the endoscopist's name needs to be mentioned over there. For research purposes, sometimes people can even include the assistant or whether a trainee was involved or not. Then comes the patient demographics, age, sex, etc. These basic demographics needs to be mentioned in the US report. Relevant and important past medical and surgical history is something which should be mentioned in the US, in the pre-procedure segment of the US report, something which can have a relevance on the outcome of the procedure that is being performed. And definitely an important concept, important aspect is the prior medications, whether the patient was on anticoagulation, antiplatelets, antithrombotics, etc. Those needs to be mentioned, including the time for which the patient have been off that. Because when a procedure is being done, then that can have implications as per the prior medications that the patient has already been on. Similarly, the need for antibiotic prophylaxis, whether the patient was given an antibiotic or not. Let's say we are going ahead with a cystic lesion FNA aspiration. In those situations, whether antibiotics were given or not. And then comes the indications of the procedure. This has to be clearly highlighted. What were the symptoms of the patient, and definitely what is the specific area which is being targeted during that US procedure. Let's say a diagnostic biliary tree abnormalities, localized tumor of the GI tract, etc., etc. Whether it was a diagnostic indication for which the procedure was done or a therapeutic indication. So the indication has to be clearly written in the report. Relevant pre-procedure investigation may be also included, such as a prior CT, MRI, or ultrasound, which has led to basically the for the purpose for conducting this basic US procedure. A documented informed consent. This is very important from medical legal aspect, that the report should contain a statement stating that a documented informed consent has been taken. Then comes the part for the sedation. The sedation details needs to be given brief, but definitely has to be included in the report. As to what is the type and the dose of sedation, whether an anesthetist was involved, then the anesthetist's name. These are important for the medical legal aspects, and whether a general or a conscious sedation was given. And definitely, as Vikram sir was talking about the preparation, the pre-procedural preparation that has been done. Let's say the patient has been kept on NPO. So how long the patient was NPO? This is again important from the aspiration risk perspective. And if, let's say, a rectal US was done, so how the bowel preparation, how good or bad was the bowel preparation? So a scoring might help. Then we come to the procedure details. So procedure details can be diagnostic and therapeutic. So when we come to the procedure details, one important aspect that needs to be mentioned in the US report is the adequacy and extent of examination. Let's say the patient already has food inside when we went in into the stomach. Let's say there is a duodenal obstruction because of which the endocrinologist could do the endoscopy only from the stomach and could not reach the duodenum. So these aspects needs to be mentioned as to whether there was a suboptimal examination or a limited examination or a complete examination could be done or not. Then comes the part of the actual part of description of the findings. So we talk about the definite landmarks, the relevant landmarks that has been used by the endocrinologist, and then the description of the lesions. So so let's say you are talking about biliary abnormalities. So the CHD, CBD diameter, the intrahepatic ductal dilatation present or not, cystic duct, gallbladder, comment on the gallbladder and the gallstone, how many are there, location, size. In a patient who has been screened for a biliary abnormality, the pancreatic duct should be mentioned upon, and the relevant vasculature. These are the various kind of a structure. That is what I want to highlight, that any US report, whether we are doing for a biliary abnormality, whether we are doing for a pancreatic abnormality, there should be a structured pattern under the headings of which the reporting should be done. Let's say for a pancreatic abnormality, parenchyma, how did it look? Echogenicity, heterogeneity, calcification, lobularity, stranding, etc. Let's say commenting on the PD, adequate description of the pancreatic duct should be given in terms of the anatomy, the margins, the echogenicity, whether there were stones or sludge inside it or not. And whenever we talk about pancreatic abnormalities, again, the biliary tree should be commented upon in the EUS report. How did the ampulla look? Let's say we talk about a solid cystic lesion of the pancreas, then the location, size, the morphology is important, whether there were internal septations or not, whether there was echogenic debris or not. So this kind of a point-wise structured report should be written so that none of the points are missed, and a complete description of the particular lesion and the important adjuvant findings needs to be mentioned in the EUS report. Let's say there is a pancreatic or a biliary duct dilatation, whether there was a communication with the PD of the cystic lesion. So these things are important and needs to be mentioned. When we talk about, let's say, a subepithelial lesion, then the layer of origin of that lesion needs to be clearly mentioned, the size, echogenicity, Doppler flow, etc. If you are doing a rectal EUS, then the rectal wall layers, their echogenicity, whether they were, what was the status of the sphincter apparatus, the bladder, prostate. So these are the basic things which needs to be clearly mentioned in the EUS report. When we are talking about fistula, the length, location, the muscle layer, penetration, etc., should be clearly highlighted in the report. Staging of tumor, this is a very, very common indication for which a person can be referred for an EUS. In those situations, the size of the tumor, the location, the depth of invasion, the T-staging of the tumor, the lymph nodes involvement, the vasculature should be clearly highlighted and outlined. If you cannot comment about a particular vessel, that should also be mentioned. While we are doing a screening, if you find some liver lesion, some peritoneal lesion, that can be easily and clearly should be mentioned in the EUS report. Comment should be made about the ascites and pleural effusion. Again, a very important point that the report should acknowledge a statement that when the patient is being referred for a staging of the tumor, that distant metastasis cannot be ruled out. There should be a statement which clearly mentions this and acknowledges this. Very often the patients are referred for sampling of the lesions. So when we are sampling the lesion, the procedure details should include a needle type, the gauge, what kind of needle has been used, whether it is an FNA, an FNB, the gauge of the needle, a 22 gauge or a 19 gauge needle, how many passes have been taken, because these are the factors which will actually have an influence on the diagnostic yield of the tissue. So what was the tissue acquisition technique? It is good to mention whether a slow stylet pull technique or let's say a wet or a dry suction was used. These are important things which can be mentioned in the EUS report. And whether an on-site evaluation was available or not, it is advisable, not mandatory, for if the endoscopist also mentions about the quality of the tissue that that he has been able to extract and how much amount of blood contamination was there or not, because that can help in future interpretation of the pathology report later on. If there is image enhancement techniques have been used, let's say a contrast enhanced EUS has been used, then the volume and the type of contrast that has been used needs to be clearly mentioned. Whether the what was the interpretation in the findings in the arterial phase, in the venous phase, and if someone has performed a time intensity curve or a tick analysis has been done, that can be mentioned within the report. Many times elastography is done, then the qualitative and the quantitative, let's say a strain ratio or a hue histogram, whatever the findings were, should be clearly detailed in the EUS report. I will not, therapeutic interventions in EUS are vast. I will not go into the details of every one of them, but basically any therapeutic interventions done, the detailed reporting should be in these following headings. What was the method used? What was the access route? Let's say a transduodenal or a transgastric route was taken. What were the accessories used for dilation techniques? Let's say a cystotome was used or a bougie was used, and definitely the specifications for the stent placed, whether a metal stent or a plastic stent, and what was the dimension and the make of the stent. Those things needs to be mentioned in the EUS report, and definitely about the technical success. Let's say you're doing a CPN or a CPB, then how much amount of injection material was used? What was the volume of the material that was used? What was the technique used? Whether it was a unilateral or a bilateral, whether a direct injection into the ganglion was done or not. These things needs to be clearly highlighted in the report. When you are going for a vascular interventions, what was the coil specifications, whether additional glue was used? If glue was used, what was the volume of the glue? So these various aspects and steps and technical details needs to be mentioned clearly in the EUS report. Again, photo documentation is one of the very, very important component of the EUS report. All the relevant lesions that you have documented on photos, some of the representative photos needs to be attached along with the EUS report. Let's say EUS report is normal, then the various important landmarks, photograph of the various important landmarks needs to be attached with the EUS report. None of the guidelines or none of the documents state about how many number of photos should be included in the EUS report, but I guess 3 to 4 representative photos should be good enough to carry on the message of what was actually there in the US findings. Sometimes these kind of labeling can be used to enable someone who is later visualizing the report or seeing the images for better interpretation, because photo documentation is one of the major indicators of the quality of the US procedure. And sometimes video documentation may be kept for beneficial, majorly for therapeutic interventions. Adverse events is something which should be clearly mentioned in the US reports. All the adverse events should be adequately and systematically reported. It is one of the very important key quality indicators. Not only from it is a key quality indicator, it is very important from a medical legal aspect, and also it would help the patient for future management. So if there was a perforation, a bleeding, cardiopulmonary events, etc., should be clearly mentioned. Not only these adverse events, even let's say there was an equipment malfunction, let's say a stent maldeployment, let's say a stent did not get deployed or got stuck somewhere, some equipment impaction. All these things should be clearly mentioned in the US report. Any allergic reaction to the, let's say, a drug which has been given as an anesthetic medication, and there was an allergic reaction. So these things needs to be included in the US report. Post procedure, there might be late events, adverse events. Sometimes if a patient is hospitalized and then later on some events develop, those things may be included in the US report as well. After this, the post-procedure segment should contain three important parts. One should be the diagnosis. So after the procedure has been done, the detailed description of the procedure has been given. A clinical impression of the endocrinologist needs to be included. Whatever differential that the endocrinologist feel about the particular lesion needs to be mentioned clearly, and followed by that the recommendations, the follow-up recommendations as to what the endocrinologists actually think should be advised for the patient. Let's say a patient has a cystic lesion, a mural needle with a danger sign, so those alarm features should be mentioned. And let's say the patient requires a surgical intervention, the patient requires a follow-up F&P, those action plan needs to be clearly outlined in the recommendation part of the report. And a statement, let's say a patient has undergone an FNA or an FNB, then a statement that the pathology report is pending or will be available later needs to be mentioned, so that this for the completion sake as well as for the future reference sake. So I'll summarize by telling that a standard US reporting template, just as I was talking about, this is a standard US template that I have made. Something like this can be used to optimize the reporting standards of EUS. And as a endoscopic society, I would strongly recommend that SGI should develop, or we should have this kind of a standard US reporting format, so that the US reporting in our country can be more standardized and have a more universal interpretability. Thank you.